passive therapy has its role in treatment. Okay. So this is an example of active therapy. The child has been given criteria, directions. His feet are on the ground. He has good posture. He's chewing, he's swallowing. He's doing an active therapeutic technique using crackers, which is what we're going to learn next week. I mean, they're bunny grams. So whether you love sugar or not, that's what he chose. And we have been doing active therapy. Now, in the background, you see this is a Myomunchie. This is active technique. And over here, we have a Froggymouth. Okay. So you're going to see that you bring in different tools for different reasons. And we sell the Froggymouth. So my disclaimer is that we're the US distributor. And it's part of the reason why I know as much as I do about it. But also the Myomunchie is a fantastic tool for for chewing, muscle activity, proprioceptive gains, and a little bit of swallowing. Here's the Myomunchie, here's the Froggymouth, okay? So you're using different tools for different reasons. We build proprioceptive awareness, we increase coordination, we're improving tone. These are all things that we do actively. We improve and optimize habits. And ultimately, we're trying to create automaticity, which is neurologic integration. Okay, so these are really kind of the building blocks of where we go with myofunctional therapy. Okay, habits extend into different domains. We have habits around chewing, habits around sleep, habits around tongue posture, self-awareness. So all of these things are kind of where we're going with treatment. Now, in the brainstem, we've talked about the somatognathing system that runs the show in terms of breathing, respiration, and coordination of head, neck posture. But of course, there's all these other parts and how memory is stored in different parts, emotional memories, the prefrontal cortex, which is why executive functioning with children under the age of 4 make it hard for them to learn and make a decision around habit elimination. The brain is developing at different rates all the time. So what we're trying to do here is pull in some of these principles about how we integrate. Now, I studied with this woman in Paris. Her name is Marie-Yvonne Fournier, and she talks a lot about myofunctional re-education, and that's from a neurologic perspective. She wrote a book called Myofunctional Therapy, Neurologic Re-education. So, La Rééducation Myofunctionnelle. So really, this is what myofunctional therapy is. It's neurologic. It's not skeletal muscle principles. It's not yoga for the face, although we use techniques to improve tone and coordination. But because of the brain stem and the regulation of breathing, chewing, swallowing, head, neck posture, the neurologic component is really important. Now, a lot of you know I'm from San Francisco, and in 1989, the Bay Bridge collapsed. And I was there. I was in a volleyball game in Marin County. And the question began, what are we going to do with this bridge that has shown structural deficits? After the seismic analysis, it was determined that actually this is the old bridge on the right. They had to build a new bridge. We couldn't go in and rebuild what was structurally unsound. So I use this as a metaphor about what we're doing with recreating a new paradigm of swallow. Now, we know through the work of Takashi Ono, he's described the tongue as a respiratory organ. It is the primary role of the tongue, which is to create space and protect the airway. And at the same time, the activation of the genioglossus, if you look at hypoglossal nerve activation in surgery and ENT, what they're trying to do is promote the tongue to move forward to get out of the airway in cases that show obstruction of the tongue, which is sleep apnea. The airway dilation activity of this muscle is the primary function of the tongue. Now, here you see, this is a pretty severe case of tongue thrust, right? Obviously, look at what's happening. We have crossbite, the maxilla is entrapped. Obviously, there's crowding, etc. But the tongue is working as hard as it can to protect the airway. So what's the role of the tongue? It's also why we need the intervention. I mean, this kid needs orthodontics. We need to get the teeth and the palate wide enough to help the tongue sit inside the palate. And this is why building your relationships, even today, who's going to do that in your community, is essential. It's really important. So this is a technique we're going to learn next week. Sorry, it's called the water trap. I want you to see. Okay, here. So basically, tongue suction, holding water up and down. You have that open and down, and then he's swallowing. He's kind of doing okay. Again, this is active therapy. And up until my introduction to Froggymouth, which, by the way, was a very slow, kind of circumspect understanding of the device, I was always using active therapeutic techniques to retrain the tongue. And Froggymouth and the team really brought in this principle around, how do we change things? Well, this is Buckminster Fuller. And again, to go back to that bridge analogy, to change something, build a new model that makes the existing model obsolete. Okay, this quote, this can apply to any sector of our experience as a human. Family dynamics, right? You could even say, how am I going to change, or how's the family going to change? I'm going to build my own paradigm. I'm going to change the paradigm. It's a principle in personal and self-development. Change the paradigm. What are the limiting beliefs I have? So beyond that, how do we change a pattern physiologically that is protecting the airway and has been since it learned that pattern in gestation and in utero? How do we change that? So we've done active therapy and it can definitely help. But here we go again with this new bridge, kind of a new way. And that essentially is what the Froggymouth is. Okay. So it's a paradigm changing device. It changes the environment and it essentially suppresses the facial nerve, the seventh cranial nerve. Okay. So with that in mind, what is it? Okay. It's passive. You place it between your teeth. You all have a medium size in your toolkit. It's the red. Okay. This is for teenagers, any child, usually around 10 and under, depending on their size, again, depends, is a small. The small is blue. It's pretty rare, but it does come in large. And this would be for larger lips. And basically, it's created by a French orthodontist to improve orthodontic outcomes and promote tongue to palate contact, change this paradigm of the swallow, and through that, even promote nasal breathing because of the tongue to palate and the lip seal. So it's almost counterintuitive that you're propping your lips open and it's going to promote nasal breathing. Well, I'll talk about that a little bit. And oral motor stability. So this is Patrick Fellus, passionate orthodontist. His interest in the brain is what really brought me into understanding the neuroscientific foundation. And I love this part. And we have this book that explains it. He wrote it. It's really interesting. Okay. So this is the book. And essentially, it describes how the passive approach is better for long-term memory because of some of the synaptic and neuronal activities that I'll describe. So this is the Froggymouth. It sits between the lips. It inhibits the motor program of the infantile or primary swallow. I'm not sure if I love those terms, but those are the movement of the tongue to protect the airway has carried forward into this tongue thrust pattern into childhood and beyond. It should phase out as the face grows, but when you have an airway challenged child, the genioglossus and muscle activation of the tongue is even more important. So as the tongue doesn't support the maxilla, the narrow palate, and AP dimension, the anterior posterior dimension, is likely not grown. So the device sits between the teeth and it forces a discovery. And that's the real operative word. The placement of the Froggymouth between the lips, which I would like you all to put in your lips right now. If you have your device, you're going to open it up. It's in a little bag. Okay. You have this device. It comes in a little plastic thing. Open it up. And then you're going to see on one side, there's a little notch. Okay. That's going to go where the lip. This is kind of a new design to orient. And only the lips sit in the vestibule of the Froggymouth. Okay. And it's effectively just propping the lips open. Now, you're just going to listen to me. And I'm going to talk about it. Okay. I should have done this at the beginning. But the Froggymouth is just basically you are distracted by discussion. Okay. And you're sitting in a way that's beneficial for gravitational forces. And you're going to have to clear your saliva sooner or later. Okay. You're just going to have to do that. What you're going to need to do is clear your saliva, but now because you have this device that's inhibiting facial nerve, it's going to be a little harder. And if you have a thrusting pattern, your lips are always involved because the lips create the pressure of the tongue. So you need pressure chambers in order to effectively create the force for the swallow. So now your lips are open. And how the heck are you supposed to swallow if you can't activate your lips? Well, that's the discovery. And it might happen quickly, or it might happen after several recurring sessions. This is why the unconscious piece of this is what you kind of have to trust, that the brain is learning something new. Now, this is the part that I think is interesting. So this man is Eric Kandel. He won a Nobel Prize in medicine in 2000, looking at learning and memory storage. And what his work showed is that cases where there's an increase of neurotransmitters in the synapses results in short-term memory. Now, what creates an increase of neurotransmitters? Well, usually the sympathetic response, okay? The activation, the methodology. So the child who's sitting in front of the mirror, there's an increase of neurotransmitters. And this happens inside the synapse. What does short-term memory mean? It means that the child might learn that in that time frame, but has it integrated into the pattern over time so that there's no thinking involved. So the slight stimulation of stress releases neurotransmitters in the synapse. The nucleus is not involved. And that's why if it doesn't involve the nucleus, it's not embedded in a deeper subcortical memory location slash kind of dynamic. And so it doesn't integrate. So we have short-term versus long-term memory, and stress is going to activate what your body needs in that moment to figure it out, but how do we do this to get it more long-term and integrated? And that's why there's a time period with 15 minutes of having this device in your mouth, and you are distracted. Okay. So this part of the patient in a cortical imprint, this is active therapy. The patient is aware of the gesture and then does repetitions and hopes that it becomes automatic. And that's what we learn as active myofunctional therapy techniques, just like the kid in front of the mirror. But as I said, is that really lodging in the brain with longer memory consolidation? And so this is where the Froggymouth, 15 minutes a day, the patient is eye level, about 4 to 6 weeks, maybe less, depending on the stress level of the child, minimal directives, and the discovery of the swallow is what makes this effective. If you were to exceed 15 minutes, you would become adaptive, and the neurotransmitters would remain outside of the nucleus because of adaptive stress techniques. But if you do short bursts, 15 minutes, you have neurotransmitters that actually pass through the nucleus in a certain methodology, and it bypasses the facial nerve. And this is the discovery and new paradigm. It doesn't interfere with cortical information, which is kind of top level directives. This is unconscious. You don't want to think about it. So look at the child on the left. He's really struggling. He's just been placed with the Froggymouth. He always uses his lips to create the pressure. Now the lips are suppressed. The stress and tension is creating the forced discovery. It is not comfortable with a child like this, who's actually 3.5 years old. So he's a little bit younger. Okay. But after 1 week of every day, 15 minutes, sit down, watch a show, eye level, be distracted. Look what happens over 1 week. Okay. So do you see how he just swallowed? He's still got work to do because his eyes are kind of moving. He's kind of discovering and finding it. But the discovery in just 1 week has allowed his tongue and palate to make contact. And then his body figured out that's how I can clear saliva. Okay. Now, over time, that gets more ingrained. So this is kind of why I love the Froggymouth. For one reason, it's working on a whole different level. Another very practical reason is that you don't do anything. After all these techniques and all these directives and all these exercises, it's like, this is great. I don't have to do anything. And you're like, nope. Now, you might find that kids salivate and their fluid increases and they can't figure it out. Sometimes, if that's the case, a small directive of a tooth together swallow, and then you do the swallow. So what this study has shown is that at rest, this was an MRI done on a child. Okay. This is at rest. This is when swallowing normally. Okay. There's some activation right here. And then on the right, this is using the Froggymouth for the first time. A lot of activity. It went from no activity to using this Froggymouth. It's the brain is ignited and turned on to discover how to solve the problem, how to clear saliva. Now, this is without the device, March 21st, 2016. Okay. This is with the device again. Activation is happening in the brain. 1 month of using the Froggymouth. And then we have this. This is without the Froggymouth, but the brain is still activated. And this is the new paradigm that has integrated neurologically. So that's really the piece of this that finds relevance for me as a clinical therapists trying to see how can we get integration, right? And it's inside of 1 month. But the variables of this child have to be thought about, okay? How much stress is in the system? How much sleep is actually happening for this to happen, right? So the Froggymouth works with less stress, better sleep, because you have better brain recruitment and integration. Okay, so, these are just some examples of, over time, what can happen when your tongue is trained to go into your palate and not into your teeth. Okay. Obviously, that's where we're going. And that was with using the Froggymouth. Okay. So this is very attractive to orthodontists, because we're addressing functional challenges that created the problem in the first place. Well, actually, I wouldn't say it created. The airway issue is what created the retained reflex of thrusting. Okay. The pattern didn't move into tongue to palate. So you go from this to this, because the function of the tongue was changed. 2 weeks with Froggymouth, open mouth, less. Expansion maxillary. So again, using other tools, and then with a device like the Froggymouth, I think you get a lot of benefit. This is expansion, and then with the Froggymouth. So the Froggymouth is the stability of the tongue. Okay. So that's kind of the idea. These are syndromic cases. Obviously, you see some growth elongation. This is, what we see. And over time, with multiple modalities, if you don't change the function, you're going to stay in a state of instability. Okay. There's some studies that show this. I wouldn't say they're that strong, to be totally frank. They're articles, prospective studies, but some research, and I think there's more coming. These are examples of, pre-Invisalign with the Froggymouth. You can use this with other devices, etc. The delivery, and then over time, hopefully all of these things, you see the bite is starting to close. Okay, because the tongue is up in the palate and it's not the barrier. Okay, so for you, I would say you are adults. So you see how you don't want the corner all the way to the lip. Okay, you don't want that. I don't think anyone here has that. So you get a medium, but you can err on going smaller if you have a small mouth. I wouldn't get a large, because the lip itself, if this is going all the way out here, it might create some friction, and you don't want that. Okay, how young can you use it? I personally started my youngest at 3.5, but I just was at a conference in Salt Lake City, and I had 3 people come up to me saying they use this with their droolers, one of which with all the 2-year-olds. So I personally haven't done that, but she said she gets really good results with even young kids. It's really more about the behavior of the child. How active are they? How can they focus? If they have a screen, you want the distraction. Okay. But that is kind of the whole gist about the Froggymouth. And it's a tool that's passive and I think very effective when mixed with all of these active techniques. I like to bring it in at around this session 4. But you can bring it in later. I think it'd be better to bring in later and do active therapy building up to it. But if you feel like we just have to try something new, bring it in sooner. I'd like to gain proprioceptive development before I do that next part. It's a really helpful tool. Okay. So for the SLPs, the questions are always billing. These, there is a code for oral, they're medical codes for oral device. And so that might be something to think about. No, do not sleep with the Froggymouth. This is not a sleeping device. The minute you get into anything longer than 15 minutes alone, you're creating an adaptive response that is neurologically not as stable. And you don't want that. You want the novelty and the solution and discovery. And that generalizes into all arenas. But you don't want to lie down. You want to sit with your eyes level. 15 minutes, 1-5. Only when they're distracted. Yes, that's why you put on a movie, but it has to be eye level. So the best would be to put up a computer, eye level, put it on blocks, put up a laptop, or if they have a TV, just, you don't want the eyes going up. You want it more eye level, just because of the dynamics of the tongue and swallow and gravity. Yeah. And if you're bringing this into your therapy, you can just add, you buy it. This is only sold to clinicians. Okay. You buy it, you give it to them, and you tell them how to use it. That's the best method. It's like I said with the myospots, the way you guide and help people know what to do is at the basis of how people take it seriously and comply. Okay, so for yourself, I wanted you to experience it. And Mamta, what are you finding?
Yeah, I noticed, first of all, I'm drooling a lot, and I'm like definitely trying to use my lips to like pull the
Mhm,
drool to the back of my mouth.
mhm.
I don't know if you have any advice on how I'm
That you're
supposed
in the discovery phase.
to, okay,
So
that's
the
what I figured.
drooling is because you haven't figured it out.
Yeah.
Okay. Now, with a kid who's like drooling all the way down, the recommendation is a light tooth together swallow. Light tooth together.
Okay.
Just gently press your teeth together.
And then the other thing I noticed too, I know I used to have a tongue thrust swallow, and it's something I've been working on, but I'm swallowing a little bit of air. I'm kind of like burping. So there's
Yeah.
definitely some like room for improvement with my swallow.
Well, I mean, first of all, great self-awareness. That's key. Secondly, a little more tongue to palate compression
Hmm.
is what you need. So a little more posterior contact with your tongue to really close up that air bubble.
Yeah.
Yeah, but you're doing it. So again, repetition. This is something that in your case, because of a history, I'd be very curious, just 15 minutes. As a clinician, you're going to be overly analyzing everything. So it's hard to let go of that left brain when you're doing this. But that's why watch your favorite movie, get lost in something. Don't get into a scientific podcast. Like, don't put on Andrew Huberman. Put on a right brain journey so that you can relax and let other parts of your brain run the show. You're laughing, Mina. That's funny. Yeah, go into like a scintillating uh mini series, a murder or something. I don't know, affairs. Like, go into another world. Just do not live in your left brain, is what I recommend. Yeah. English drama. Oh yeah, let's get into it. All the layers, all the costumes, oh yeah, totally. We're in. Okay, so I would love you all, if you have a history with thrusting, this would be something that I would be curious about how you navigate. But again, turn off your brain and just let yourself get lost, because that's how it works. It's not the thinking part. We're not thinking ourselves out of this problem. We're allowing the brain and tongue to discover, which is the long-term memory piece of this. It's a new paradigm. New paradigm. Yeah, I really love it. I love it. And I think once you get more familiar with it, you'll understand. It's also nice that people don't have to do a lot. Mhm. All right, ladies and gentlemen, I think we've wrapped it up. It was a great session. Thank you for being here. I always appreciate when you come here and um, give your attention and are still here learning. And next week is an exciting, it's the day after Halloween. So we'll be okay if you have kids. But we're going to talk about chewing and swallowing with food. So bring your food. Okay, we're going to talk about some of these things we even described earlier when we had our first weekend. Oh my gosh, I love all the. Thank you. This was great. I love our class. You are so wonderful. I appreciate your questions, and I mean it. It's very dynamic, your questions, and I feel the curiosity. And if you're skeptical, that's very appropriate as well. So bring your skepticism through this by applying it into a journey of experience.